Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program here on Power 96.5 FM, WUFO 1080 AM. Well, today, you know what? We're talking about something we talk about, right? It's part of conversations. And I don't know if people actually, I know people are listening, but it's something that we really have to start taking seriously. And I mean, the entire community. And that's cancer. We talk about, we know, everyone knows somebody, all listeners. I'm going to say 99.9% of us know somebody who has had cancer. So today we're talking about cancer screenings and prevention because we don't know if that loved one has made it or not. But today, I just thought, I know there are a lot of different cancer months. This month is can, but cancer lives with us every single month. So that's why our guest for today is Dr. Schweitzberg, and Dr. Schweitzberg is a friend. Been working with him for years in this area. And Dr. Schweitzberg is the SUNY State University of New York Distinguished Service Professor, Professor and Chairman of the Professor of the Biomedical Informatics Department of Surgery at the Jacobs School of Medicine, UB Med School, and Biomedical Science. That's quite a title that I know he wears his title well. Dr. Schweitzberg, you are a distinguished, first of all, I want to welcome you to the program this morning. How are you?
I'm terrific, Francesca. Thank you for the invitation.
Oh, you're welcome. I'm so happy you could make it. Now, you are a distinguished service professor. How did you get to the goal? I want people to hear just a little bit about how you have gotten a distinguished service professor. What does that mean?
Well, it starts by, the academic pathway to become a physician and a surgeon and a professor is a journey. It's a 20-year or more journey. If you think about, the role, you go to 4 years of college and 4 years of medical school. I did 5 years of surgical training, so that's 13, 2 fellowships, that makes 15. And then I started my career at Tufts University in Boston as an assistant professor. And for people on the academic trail, we do research, we write papers, we teach medical students and train the next generation. And then you become an associate professor and you keep doing more and more. And I left Tufts and went to Harvard, where I became professor of surgery before coming here. And here at Buffalo, where I was appointed professor and chair for the Department of Surgery, we did many years of work and service doing, cancer screening and social justice and health equity work and innovation and work to the profession, and was nominated by Michael Cain when he was the dean to be reviewed at SUNY, which is 62 colleges and universities, to be considered and appointed a SUNY Distinguished Professor. So it's not an overnight thing. It's probably a 30-year journey.
And that's wonderful. And I also want to say to our listeners, you probably have seen Dr. Schweitzberg at a community event. You might see him grocery shopping at Wegmans. So he is part of the community. He's not only working in oncology and cancer. You probably have seen him at an event. You may even see him at one of our plays. We have a great play taking place right now in Buffalo. So I just wanted to share that with our listeners. How long have you been working in the area of cancer and oncology?
Well, I've been, after my training, a surgeon for 38 or 9 years. And I've been doing cancer surgery since then with different focuses. The whole treatment of cancer has become more and more specialized, but throughout the course of my career, I've taken care of pancreatic cancer and colon cancer and gastric cancer, and have focused a little bit more in the last couple of years on thyroid cancer. I am the chair of the Kaleida Health Cancer Accreditation Committee. So I am concerned with quality improvement, care of patients, cancer prevention, cancer screening. And so this has been part of my career for nearly 40 years.
Thank you. And so I know you have seen you've seen treatments come a long way in terms of the medication. I have a friend now with stage 4. Breast cancer came back, but she's doing great, you know? So that's why we have this show today. How important are cancer screenings?
Cancer screening is the gateway to diagnosis, and that is the gateway to treatment. And I can't overemphasize how we need to get behind this in our communities, in our families, in our friends. Many cancers have no symptoms. And, you know, science is amazing. And you alluded to the fact that people are doing better than ever before. When I finished my training, having stage 4 cancer was 6 months to live or less. Now, for many patients, they can be cured. And so the goal isn't to cure people with chemotherapy. The goal is to find these cancers early, because the earlier we find a cancer, the less invasive the therapy is, the possibility that you won't need radiation or chemotherapy because your cancer can be cured. And, you know, the truth of the matter is, our populations of people who have problems getting access to screening present with later stage cancer.
Yes. You know what? This topic is emotional, so I just have to sometimes get a grip on myself. What age should persons over 18, or I guess my question is, what age do you begin screening? And I just say 18. I'm thinking about if you're coming to apply for a job here at Kaleida, you have to be 18. So that's where I got the number 18 from. So I don't know if 18 is the correct number. I'm just guessing. But what age should people begin screenings for cancer?
A lot of it depends on, you know, family history. Yet, and nobody would advocate for routine screening at 18 in the vast majority of people. But we know there are childhood cancers, and we hear these tragedies, but those aren't screening failures. Those are just bad diseases. And one of the things that we've seen over the years is an increasing number of people in their 20s and 30s with colon cancer or breast cancer, not so much prostate, ovarian cancer in their 30s. And so we need a couple of things. We need people to understand that the genetics of their family history is important, and that genetic screening in certain families is critical. Breast cancer is a good example. If your mother or your aunt had breast cancer, then screening not just for breast cancer, but for the genes that cause breast cancer become critical. I have a family friend who he himself had prostate cancer. His wife just had breast cancer. And, you know, they were very concerned for their daughter, who is in her 20s. So it doesn't sound like much of a cancer age. They did the genetic screens on her, not a mammogram, but the genetic screening is part of screening. And she's at an 87% risk of having breast cancer in her immediate future, and made a decision to have mastectomies in her 20s to prevent that breast cancer risk. So it's the cancer screening, but also in some cases, the genetic screening in those people whose families have a strong history.
Yes. And how do you begin the conversation? Because, you know, not all families are going to talk about cancer. Sometimes people don't know how they passed away. What's a way to, I mean, do you have any recommendations on how to begin a conversation, or when should this conversation begin? Should it begin earlier, in your teens? Should it begin in your 20s? About who, like, what did mom had, grandma, auntie, dad?
I think it's hard to have that conversation with an 8-year-old, but your point, Francesca, is really well taken. You want to learn about your families before we lose them. And so much family knowledge and wisdom is lost if we don't ask the questions. As a teenager, we're often not smart enough to go, what should we do? So it's up to us as parents to inform our children about what happened to their relatives. So I don't think, teenagers is too early to tell the family history of what has happened in their family. That's a good time to start.
Yeah. And you know what? I'm going to have you name the cancers that you have said are you're seeing in the people in their 20s and 30s and 40s. I just want to make sure our listeners got that.
Well, sure. We're seeing colon cancer in early age groups, which is why screening recommendation for colon cancer has moved down traditionally from 50 into lower numbers if there's a family history of colon cancer and related cancers. We're certainly seeing more breast cancer in younger women, and so asking the questions about related history. Many young women have breasts that are too dense for mammograms, so there's other modalities like ultrasound or MRI. So we're seeing that. In our own friend group, we've watched people leave too early, young women in her 30s dying of ovarian cancer. And the question is, could any of this been prevented if they'd had genetic screening and knew she was at risk? Those are the probably the most important ones. We don't see that much gastric cancer. Thyroid cancer is much more slowly growing, and so we have time to make those diagnoses. If you feel a lump in your neck, you should see your doctor, and often the first step is an ultrasound, something like that. But, ovarian, breast, and colon, I think, are probably amongst the big three.
Mm-hmm. And speaking of feeling a lump in your throat, I know of someone who recently was diagnosed with cancer of the saliva glands.
Sure.
So it can. Okay, I'm going to come back to that question because so is there data that indicates certain screenings should be taken, I don't know, a little more seriously for people of color? And if they are, and if yes, what does the data show in terms of what demographics, race are getting some of the cancers that you've been talking about?
Well, prostate cancer comes to mind in our communities. The Department of Urology has been, aggressive in trying to get into the communities, but, we should recognize that there is sometimes a sense of mistrust in underserved populations, but we need to be aggressive in delivering the message that we care about you, and the only way to make a diagnosis is to screen. So prostate cancer is one. Men over 55, and there are particular risk factors, people with reflux, people with obesity, people with a family history. And one of the odd ones that we're focused on are first responders and firefighters have a 62% increased risk of esophageal cancer. So we've been on, different programs and TV talking about risk factors for esophageal cancer because it's very lethal. But if it can be diagnosed early and even in the precancer stage, we can save lives and prevent deaths. So there are ways to identify patients at risk. I want to reach out to all the first responders. If you have reflux and have been a firefighter and you're over 55, please reach out to us because we can arrange for screening to see if you have any of the cells in your esophagus that are at risk for cancer. Colon cancer, nobody wants a colonoscopy. Actually, nobody wants the prep. The colonoscopy itself is not so bad.
I was going to say, because I had one and I felt great after.
Right.
I felt clean.
Yeah, yeah, no, but people talk about the prep and the colonoscopy, you get sedated. I don't even remember mine. But
Mhm.
we're coming up with new modalities of looking for cancer cells in the stool, and there are ways, but it's important to be screened. So
Yes.
we're all procrastinators. I did not have my colonoscopy till I was 52, and I brooded over it, thinking, oh my goodness, I've waited. I've missed my chance to be timely. My colonoscopy was clean, but in the bed next to me was a woman who gave herself a colonoscopy as a birthday present for her 50th birthday.
Oh,
And by coincidence, she was in my clinic a week later because her test was positive.
oh,
And so we need to be proactive. These are preventable deaths. And the truth of the matter is, the most disadvantaged people present in later stages because they are mistrustful of the need to get screened. And we somehow need to break down the barriers. And 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 if you want to be businesslike about it, it's actually less expensive to take care of an early cancer than to wait till it's spread all over the body. So it's not just good care, it's not just good community, it's not just good conscience, it's good business as well. Because for many people, if they're not working, they're not eating, they're not paying rent. And our ability to cure your cancer as a polyp is a day in and out of the hospital, and you can go back about your business the next day versus perhaps being out for the rest of your life and not being able to take care of your family or yourself.
yes, or yourself. Any others? So we have prostate cancer, esophageal, colon. Any others that show higher risks in people of color?
Well, breast cancer is another one, and because it's really about access to screening
Yes,
and getting an initial mammogram, not putting it off, um, you know, either taking advantage of mobile screening. Some programs have mobile screening, um, but screening and mammography is the gateway to the diagnosis. And we need to continue to lower the barriers to screening, because in the state of New York, if you have cancer and have no resource, there are finances available from the state to make sure that all cancer patients are taken care of.
hmm and again, screening so we can catch it earlier.
The earlier you catch a cancer, the less invasive the treatment is, and the earlier people can be returned to their quality of life.
hmm so that's breast. Any others? We have prostate, esophageal, colon, breast cancer. Any others that,
Sure. For women, making sure that they are with their primary care doctor or their gynecologist so that they're on the appropriate screening schedule for pap smears. Now, we used to pap smear everybody every year. We found out that that's not quite necessary. You'd have to interview my wife. She's the gynecologist. But
yes,
but still, there's a need to screen. You need to have educated, and this is not my area of expertise, educated discussions about HPV vaccine, because
yes.
these are preventable. Again, not varying symptoms, so that at least an ultrasound could be performed or a physical examination. So these are incredibly important. And the same genes that put people at risk for breast cancer put them at risk for ovarian cancer.
And they don't say enough about that. And I'm not a medical professional, so sometimes I get, well, how do you know that, Fran? Just probably because I had some, I've known people with ovarian cancer, and that's how I found out about breast cancer. But so it's like, don't ask me, ask your primary care physician or oncologist. Um,
But we need to have proactive patients, Fran. So we do the most common group of women to get gallbladders are women in their 40s who have had children. And yet, in the old days when we used to make incisions, it was routine to reach down and feel the ovaries and see if there's anything abnormal. Now that we're pointing laparoscopes, towards the liver, I still turn the laparoscope around and take one last look at the ovaries in any of my, women patients in those age groups, because you never know that if you simply look, what you might find. And I will tell you, simply by being proactive, I have diagnosed an ovarian cancer that would have been asymptomatic, undiagnosed until it would have been potentially terrible. And so I will tell you, if you're waiting for your gallbladder to be taken out, you should tell your doctor, please turn the scope around and take a quick peek at my ovaries and make sure I'm okay, because it costs nothing and it takes less than a minute.
And as I say, this program is about education and is about education, educating our community, educating all of us. And that is a good educational point, because I'm sure there's nowhere that says to tell your physician or to ask your physician to turn the scope around. So that is just that's a good tip.
Maybe that will be our slogan, turn the scope around for 1 minute.
Turn the scope around, and I think I also wrote something down already. One of your quotes: "Screenings are something about our gateway to diagnosis." So I've been writing some of the things you've been some of your quotes this morning. Yeah. So,
and for your listeners, what Fran was alluding to, I literally run into her everywhere, and it isn't even near my neighborhood. I could be out, 10 miles from my house, and there's Francesca walking into the Verizon store. It's like Francesca is literally everywhere in the community.
I love the community. I love our community, all of our community. I love Western New York. So yeah, thank you. And in your opinion, so what are some of the things? What are some of the reasons why people shy away from screening? And what's your advice for people who are afraid? I mean, some people make an appointment and they're ready to go that day, and then they cancel. Even if the sign says there's a $50 cancellation fee. Why do you think people shy away? And what's your advice?
Without being too metaphysical about it, God helps those who will help themselves. And this is part of self-help. This is part of self-care. And it is really hard. Many of us are busy. Many of us are worried about taking a day off of work. And maybe you should have a me day where you see your doctor and you get your colonoscopy and you arrange your mammogram. And we could be more efficient about, preventative, care times. But if you don't look, you don't find. And for people who don't want a colonoscopy, then some of these alternatives like Cologuard or FIT testing might be viable. But if it's positive, then your colonoscopy will have value. The same way that we do the esophageal screen, it takes a minute. If the test is positive, then we'll do an endoscopy. But you have to be there for your loved ones. There are certainly any number of tragedies of busy people, including physicians who make, I'll just say it out there publicly. We make the worst patients, by the way. And it's true. And I would put myself in that, and I try to be a better patient. But we need to make time for ourselves. We need to prioritize the fact that people will care about us if we leave this planet prematurely. And we should not just do it for ourselves, but do it for our friends and family. Yeah,
thank you. That's so true, because I like that, a me day. And if you don't have, let's say you've almost used up all of your sick time, your PTO time, whatever they call it on your where you work. Ask the scheduler, the person scheduling your screening, for a morning appointment. Or if you have to pick your children or grandchildren, foster children up from the bus stop, ask them for their first available appointment. Ask them what time do they start, and then ask them for the first available appointment, because you can ask that question. You don't have to take the appointment someone gives you. Take the appointment that works around your schedule, so you can make the most out of your me day / your me time, because the screenings are key. They are the key, they're one of the keys to life. And we want all of our listeners and their family, extended family, we want them to live as long and have a quality of life as they can. And
part of the philosophic thing one needs to wrap their heads around, you actually have to screen a fair number of people to find one. And so you say, well, in a colonoscopy, the chances are about 1 in 100 you're going to have a cancer. Well, you go, well, that's not going to be me. But that means it's not zero, it's one. And the same people, somebody's going to win the lottery, somebody's going to have a colon cancer. And so, some people say, well, you got to screen so many people. Where's the value? The value is in preserving life. And people need to understand that screening is the only way to diagnose cancer, because when it presents with symptoms, that means it's presenting late.
And as you opened your statement, is that many times you don't even know you have the symptoms. There are no symptoms until you get screened. But like you said, every 1 in 100 person. So just because I just can't say enough about screenings, because I've seen, great results of people have gotten screened, and then others, who aren't as lucky. But cancer treatments have come a long way. Dr. Schweitzer, we have 3 minutes left. What is it? What are some of the most important things, some important tips you would like to leave with our listeners? Oh, number one, how to contact you, or contact, what office should they contact if they're interested in following up on screenings?
Well, from a Department of Surgery point of view, we have a UBMD website. We're not hard to find, so you can just look us up on Google at UBMD Surgery, and you can be directed to the right place. We have resources within all of our major hospitals in the city. I personally work at Buffalo General, and our teams work at Buffalo General and Oshai and the VA and ECMC and Millard Fillmore Suburban, but there's other good hospitals in the city. But people can, get on our website, and if they have a question, use our contact page, and we'd be happy to direct people to the right place. We want to treat your concerns as if they're personal emergencies. Though many cancers are slowly growing, a breast lump will not be worse tomorrow, but it's a personal emergency. It raises questions. There's fears about life and family and children. And, if you're a 40-year-old woman and your kids are probably just teenagers, you have cares. So we want to get you in and reassure you, or take it head on as efficiently as possible. Don't miss your colonoscopy appointment. You can look on our webpage. We've got plenty of access between our colorectal surgeons and our GI colleagues. We have plenty of ways to do this. If you feel a lump in your neck, go to your primary care doctor, get an ultrasound. There are so many ways to do it, but you can reach us personally by going to our UBMD surgery website.
And for our listeners, I have to say, if you're coming in at the end, this program you can find this program on the Kaleida Health website, or just Google Kaleida Health, Great Lakes Health Radio, or just Google, or any of your search engines, Great Lakes Health Radio, Kaleida Health. But I know for a fact that this program will air again, because this information is timeless. And this information is priceless. So this is information that all of us need. And can I ask you back for maybe another show, Dr. Schweitzer, where we can go into detail on some of these cancers that you've mentioned: prostate, esophageal, colon, breast, pap? Can I invite you back?
Of course, and I can also put you in touch with the true experts of each disease process.
Okay, that sounds like a plan. I like that. Well, listeners, I want to thank our guest today, Dr. Steven Schweitzer from there's so many titles: SUNY Distinguished Service Professor, and he's also in charge of the Kaleida Health Cancer Accreditation Foundation. But I want to thank you for being our guest. Don't go anywhere, because we have another exciting show following this one on diabetes. What's new? Thank you, Francesca Messiah, Manager, Community Health Improvement, Kaleida Health. And now on to part 2. Good morning, good morning, good morning, and welcome back to the second half of the Great Lakes Health Radio program here on Power 96.5 FM, 1080 AM, or you might be streaming. And if you're streaming, thank you. Thank you for listening. The second part of our program, this is a part two. Matter of fact, you may have heard part one, but this is part two. And what's it on? It's on diabetes. Uh, One of the reasons why, because when I ask people in the community what is a topic that they would like to hear more of, diabetes is overwhelmingly the that and bones and diabetes. So our guest for today is who is back with us, Dr. Kelly Cardamone, and she is the manager of nutrition and diabetes here at Kaleida Health. Kelly, I want to congratulate you. I know I have before on your PhD, but could you just let us know all the different degrees that you have?
Hello, thank you. Thank you for having me.
You're welcome.
I know I do. I'm the lifelong learner. So I actually I have a bachelor's degree in exercise science. I also have another bachelor's degree in nutrition and dietetics. That's how I became a registered dietitian. I have a master's of science. The focus was in adult education, and then I have a doctorate of clinical nutrition and many certifications, as you know.
Yes, yes, yes. Thank you so much. And the reason why for this show yesterday, or a few weeks ago, after Kelly and I hung up, or maybe it was during the show, she said something that really piqued my interest: the 7 steps to diabetes control. Um, I've never heard this. I've never heard anyone mention this in the community. And that's why I want to share this information with our listeners. And Kelly, so who should be listening to the 7 steps to diabetes control? Is it someone with type 1 diabetes, type 2 diabetes, pre-diabetes, juvenile diabetes? Who should be paying attention?
Sure. And how about this? I'll briefly give a couple seconds just on what it is, right? So, we have an accredited diabetes program, and it's the Association of Diabetes Care and Education Specialists, and we call it the 7 self-care behaviors. It's an evidence-based, we call framework used in diabetes education. It guides people towards effectively, managing their diabetes and or pre-diabetes. And it really is an outline of these skills, which we're going to talk about, that every person with diabetes needs to maintain blood sugar, blood glucose control, prevent complications, and really improve their quality of life. So again, it's this framework, it's the foundation. Going back to your question of who should be, following these, actually, there's several groups of individuals that can benefit from these 7 steps or self-care behaviors. People with type 2 diabetes, individuals with type 1 diabetes, people with pre-diabetes. And right now, there are more people with pre-diabetes than diabetes. And really following these steps can help reduce the progression to type 2 diabetes by 40 to 70% is what we know so far from research. Individuals, so women with gestational diabetes. So those are individuals who have basically, they develop diabetes during pregnancy. So following these self-care behaviors can help manage pregnancy related blood glucose changes and reduces the risk for future diabetes. And then lastly, people that are high risk. So we've got these metabolic disorders. Maybe they're overweight, obese, they have a family history of diabetes, metabolic syndrome. And maybe not all the self-care behaviors will apply to them at this point in time. But again, it's a really great framework.
That is just so amazing. And I know, just a side note. I don't know if you read the story. I read the story yesterday about a woman who had the largest baby at Golisano
Yes.
Children's Hospital. She said she had gestational
Yeah.
diabetes, and her baby was born at 14 pounds.
Yes.
Yeah. So I didn't know that's another category, just gestational diabetes, because I have known of a few women who have had that, and I don't think everyone understands what that is. The show is all about educating, educating the community. so they know
Yep.
what questions to ask. Something I didn't ask, I wanted to ask earlier, contact information. Now, we talk about the seven self-care steps to diabetes and just diabetes education in general. Your practice at general physician, your slash Kaleida practice at general physician, are they seeing new patients if people had wanted to come and come and become a patient? I mean, are you taking new patients?
Yes, we are always taking new patients. Diabetes is always covered by insurance, Medicare, most Medicaid plans, commercial plans. A lot of individuals with diabetes also have renal disease, so kidney disease. And so that's something else we address. And I also want to share we have an accredited diabetes program. It's a 4-class, so 4-week series we've got 5 classes in the fall. We usually do another 4 to 5 in the spring. We have a telehealth option. And all of that is located on our website. I'll also give our phone number. But I just want to kind of talk a little bit. You said with gestational diabetes, we have a dietitian in our practice, Julie Baudo. She's fantastic. She specializes in women's health, and she sees our patients that have gestational diabetes. As soon as you are diagnosed, that they want you to see a dietitian, for the most part immediately to help, reduce the risks that come along with having diabetes newly diagnosed during pregnancy. The phone number for us, we do require a referral from your physician, but I have yet to have a physician, decline a referral if a patient asks. The number for us is 716-748 4000. So 716-748-4000. And then Christy, our amazing admin assistant, will help you out with the next steps.
Thank you so much. And again, this is about prevention. So I just know that sometimes I'll do a show and I'll forget to ask, or it's rushed at the end. So healthy eating, exercise, medication are things that we often hear about. However, what we don't hear about, and what I found when I did a little bit of research in this area, self-care, were things about things we don't hear as much about diabetes is problem solving, healthy coping, and reducing risk. Is that part of it? I mean, problem solving sounds great.
Yeah. Yeah. So, and then thank you. No. So how about this? So yes, it's healthy eating, being active, monitoring, actually, which a lot of people don't realize is tracking your blood sugars and glucose, to identify patterns, adjust, medications with the help of your providers and prevent your blood sugar being too low or too high. Taking medication, as you mentioned, and then we get into the ones that are not as thought of as much. Problem solving is tremendous. And here's the thing, and I think I've mentioned before on the show. As a patient, we provide, our plan is we give you the guidebook, as I call it. So we give you the education, and we give you the tools, and then we send you home. And then now, right, you have to practice it. You manage your, not just diabetes, but other chronic illnesses more than we do. So we have to make sure we're giving you all the tools and supports you need, right? That's why I love classes and what my dietitians do. Problem solving is managing unexpected challenges, right? So it can be illness. So because when you get sick, that stress response in the body, a lot of times your blood sugar will go higher, blood glucose goes higher, even if you're eating less. And it's the stress response in the body. And a lot of people don't understand that. So we tell them you still have to take medications, you have to stay hydrated. How about when you're traveling?
Yes.
Changes in your routine. So we do a lot of what we call sick day plans and, teaching people how to manage hypoglycemia. So that's the problem solving. Reducing risks. And I think we get into that a little bit. And is, talking about the organ system that it, impacts, but it's preventing long-term complications through your routine screenings, vaccinations, blood pressure and cholesterol management, and smoking cessation. So you want to make sure that we're figuring out how to problem solve. So give patients the tools. How do you reduce these risks? Because having diabetes increases your risk for heart attack and stroke. And then we have something called healthy coping. Diabetes distress is real. And we don't always talk about it enough, that it is overwhelming for patients. And a lot of times that is either, knowing how to manage that is so essential, because patients don't know what to do, meaning it's the psychological, the emotional aspects of diabetes. So we help them to build resilience. We try to reduce the distress and honestly give them access to social and professional support. Again, that's why I love the diabetes classes. They're group classes. You get a lot of group support, and patients find them really helpful.
When I went to the diabetes years ago, with my mother, rest in peace, I went to the classes with her and I learned a lot. For the classes, can people bring somebody with them sometimes two sets of ears are better than one.
Yes, we encourage people to bring a support. I think anything major medical, in your life, you want that extra set of ears. Sometimes, as you got more people, they'll catch something and learn something differently than you did.
Yes.
There's a lot of information. So yes, to have more than two ears is better. And a lot of times too, individuals with diabetes, the family needs to understand what's going on. The family needs to be able to understand the whole scope of everything, including that, the healthy coping and reducing risks, because a lot of times that's a big challenge for patients. They go home and the family doesn't fully understand what they're dealing with. And it's, they'll say things like, well, it's fine. You're taking insulin or medication. You can just eat that cake. And
Steak sub.
yeah, and you need everybody on board. So we encourage that. And when we do the telehealth, the video classes, I do always make the joke. I say, have a viewing at your home, meaning invite everybody because you got the space. We want everybody to learn about diabetes management. Everybody in the family, the more the better. Friends too.
Yeah, too. Yes. No, absolutely. And that's huge because, like I said, you might be listening from one of the remotely from one of the one of the on-site boxes, but you can be in a rural community. That's my point. You can be in a rural community and with the telehealth, with your diabetes classes and family members listening. Because I always say family members, if you know someone has diabetes, please don't bring that box of donuts. Please don't constantly enable them to eat something. And then when something happens, you'll be, then don't say, oh, that's awful. Well, please just be mindful and don't bring it. Leave it in your car. Leave it in your car, because this is about prevention. So anyway, can you discuss the other four areas under the 7 steps?
Sure. So healthy eating, it's a big part of it. We know that, as we just kind of talked about, there are other things that raise blood glucose. It can be stress, it can be illness, medications, steroids, things like that. But you need to take these medications in conjunction with what you eat, because basically your eating behaviors directly impact your diabetes and blood glucose. So choosing foods and eating patterns that support stable blood sugar, weight management, and again, that cardiometabolic health, meaning reducing, risk for high blood pressure, or if you have high blood pressure, watching sodium intake, watching your fat intake. We really call it like it's carbohydrate awareness, balanced meals. And I will reinforce the point. There is no one set, what we call diabetic diet. We have like this framework of healthy eating. We have the diabetes plate, which I love, which is like half of your plate should be, vegetables. And then a quarter of the plate, some lean protein, and a quarter of a plate, some good whole grains, brown rice, whole wheat pasta, can be potatoes, things like that. So the healthy eating. And we also teach individuals you need to eat several times throughout the day. So it's spacing out your meals. Try to avoid eating late at night, because that will disrupt sleep and impact your blood glucose during the night, but in the morning. So healthy eating is a big part of it. And I will share my team, and even in the classes, we address the cultural aspect of that, right? Like there are so many people with all different religious and cultural practices. And so our job is to help find something that works also within your current, lifestyle, I should say. Being active. So it doesn't necessarily mean you have to join the gym. I mean, that's great if you can, but it's regular movement. So just moving around, taking the stairs, walking around your house more or your apartment or wherever you're living, parking farther away. If you're able to walk somewhere versus, doing transportation, go for it. We do know that regular movement helps to improve what we call insulin sensitivity. That just means the insulin can do its job better. It helps to lower the blood glucose. Again, supports weight control, and it improves sleep, which is essential, and also your overall mood, right? And with that, you got to remember resistance training too. So like bands, use soup cans. So strength training is important as well. Again, don't need to go to the gym. If you want to, they got silver sneakers and classes too. And there's a lot of stuff online. And then that last one is, I should say, we'll do monitoring, taking medication, but monitoring is really looking at, so you want to make sure that an individual they're tracking their blood sugar or blood glucose readings. So either checking once or twice a day. For some patients, it's once a week. We work with the individual. Some people don't like to, prick their fingers, as they'll call it. It gives them anxiety. So you can't give somebody a glucometer to check their blood glucose without educating them on what numbers they should be aiming for or what they should be doing with the numbers, right?
Right.
And then now we've got CGM. So that's called continuous glucose monitoring. Those are the little, you'll see them, they're little circles. They look like, and you place them right on your arm, and you don't need to prick your finger unless you have a really low reading or reading that seems off. Those have significantly changed diabetes management and pre-diabetes, because patients have direct feedback on everything they're eating and doing, which is fantastic. They're fantastic. And then that fourth one is taking medication, and it's talking to patients about the correct use of insulin or injectables, understanding the timing, the dosing, side effects they should be looking out for, and really how medications interact with food and activity, and supplements. So it's addressing all of that. So it's a lot.
No, that is a lot. And I have to say a couple of things. If you are experiencing side effects, call your physician, or call your physician, nurse practitioner, call Kelly's office, let someone know. Just because you have side effects. I've been in so many conversations where people talk about side effects and they haven't done anything about it. And it doesn't mean you stop taking it. There are several medications, I think, under each category in the medication, in the pharmacy journal. You shouldn't be having side effects. And if you do have side effects, call and discuss the side effects with somebody to see if they're normal or what can be done, but don't do it on your own. That's my point. Don't do it on your own.
Yeah.
Also, and you mentioned the monitor that looks like a little circle on your arm. I was with a group of friends once, and I kept hearing this beeping. I'm like, what is that beeping? You have to pay attention to that beeping on your arm. And then I think the information's on your phone, because this person was like, well, it's just my something going off, and I know what I should be doing. But it's not meant, I don't think it's meant to be placed on your arm to listen to a beep and not do anything. Could you comment on that?
Yeah. So what happens is, it depends on how you have the sensitivity set. Sometimes it will be if it's too high. It can also be if it's too low. So it depends on how you have the range, set for individuals, and how somebody handles it. Sometimes I will say that for a lot of patients, that's one of the reasons they don't love the CGM, is because
Okay.
it will go, and then that's okay. It will go off while they're sleeping. So I'll just explain to everybody. For instance, if you're sleeping and you put pressure, like if you have the monitor on your right arm and you sleep on your right side, then it actually pushes the interstitial fluid. That's where the needle kind of sits in. It pushes it away, and the blood flow kind of pushes it away. And so then it'll read low when it's not. But someone should look at it. But here's the thing. If you're with somebody and it's going off, I try to encourage individuals to not, how do I want to say this, not necessarily draw attention to it for them, because, you know, for these individuals as well, sometimes they feel like everybody's watching them. Do you know what I'm saying? And
Yes.
so it's just, you might just say to somebody, hey, are you okay? Is everything okay? But
Okay.
but you do want to look at it because it could be because it's too high. And then they can, you know, they'll silence the alarm. But if it's too low, they may need help with that. So I think the best thing is really just to say, hey, are you okay? Do you need anything from me? And if you can do that, usually, you know, it's a good way to approach the situation. But individuals should be looking at those numbers when the alarm's going off. You don't want to ignore it.
Okay, yeah, thank you. And I guess that was also more for me. So
Yeah.
next time I'm around the person that I know what to say. Are you okay versus your alarm is going off?
Yeah.
Thank you. The politically correct way. Um, Something from the last interview, only because I don't think people really understand the importance, especially those who may not have diabetes or pre-diabetes or any of them, but may know of somebody. What for diabetes, what organs are at greatest risk? Let's start with the eyes. Are the eyes at risk?
Oh, absolutely. So the retina is very sensitive to glucose or blood sugar fluctuations, and diabetes can cause retinopathy, macular edema, can contribute to cataracts, glaucoma. It's the leading cause of blindness in adults is diabetic, um, basically retinopathy. And that is why getting your eye exam, eyes checked all the time, annually is important. But also, if you notice changes in your eyesight, whether it's blurred vision, which a lot of times can happen if blood glucose is, it's too high for extended period of time, anything like that, contact your primary care doctor, go to the eye specialist, because you don't want to just leave that. You know what I mean? And because sometimes people say, well, I think it's just I'm aging. If it comes on more suddenly, you really should get that checked out.
Yeah, and sometimes your vision just a little blurry in the morning just because it's a little blurry,
Sure.
but you're not talking about that if it clears up within like a few minutes.
Yeah. Yeah, not that. This would be like you just really notice some sudden changes. Whether it could be double vision, blurry vision, even if you get an increase in like floaters, if there's sometimes people say, oh, I've got a black spot, or part of their vision is blacked out. You have to get those, you can't let that sit. You got to get that checked out right away.
And if part of your vision is blacked out, that means you can't drive. If you have a license and you're driving, that means you're not seeing a car or somebody on the road. How about, and I know we always, what are some of the other major, we talked about your kidneys. How does diabetes affect your kidneys?
So the glomeruli, which are basically the part of the kidneys that filters, they get damaged. They get damaged by high blood glucose or high sugar levels and high blood pressure, hypertension. They also, it's the lead. So it leads to what we call microalbuminuria. Oh, goodness me. I'm so sorry. I'm trying to talk too fast. I can't even say it. Proteinuria and chronic kidney disease. So what happens is that means you have basically you got albumin that will be excreted through the urine. You've got protein through the urine, and it basically can lead to chronic kidney disease. As I shared with you before, that is many individuals, more than half of individuals with diabetes have chronic kidney disease. And diabetes is the number one cause of kidney failure. So you want to keep, again, that A1C, that's your 3-month average blood sugar reading, in check. You want to also make sure that you keep your blood glucose in check. And your doctor will be checking these things regularly, right? That's why they will do urine and blood tests to make sure that the kidneys are staying healthy.
Is there any way of knowing if your kidneys are failing in advance without going through the screenings?
Oh, I will tell you that that is one of those when it gets to that point, it's going to be in more advanced stages, just like high blood pressure. They call it the silent killer. People don't know. Do you mean they don't usually know? You don't usually feel, some people can, but high blood pressure, if your cholesterol is too high, kidneys is another one. Like if you're someone's starting to see, you know, discoloration of their urine, you know, if there's blood in your urine, if you notice there's less urine output, you're starting to get swelling in your extremities, your legs, edema. Those are things that, you know, you should be mindful of and make sure you talk to your doctor about.
Okay, and loved ones, if you notice your neighbor, your friend, someone who you're out with a lot, if you notice any of these things, please at least say to them, I don't know, what would someone say if they notice this in somebody? And what's the proper thing to say to someone other than you need to get to the doctor? What's the proper thing to say?
Oh, so again, it's one of, you know, if so one, it depends on the individual how well that they would, you know, take somebody saying anything to them. But usually the time you would know is if you notice that there was more swelling. Sometimes you'll even see it in the face, the hands, the feet. Now, sometimes warmer weather can do that as well. But if you notice something pretty significant, I always share that the best approach is to ask, hey, are you okay? I've just noticed this. I'm just worried about you. If you can always take it that, you know, with that approach versus, oh my goodness, what's going on? I've noticed, you know, I mean, to be more critical, to if you can shift it to more supportive, are you okay? I've noticed this. I'm just, you know, just concerned. That's the approach you should take with somebody. You know, you might, a lot of times individuals, depends on their relationship with someone, whether or not they'll talk openly about what's going on.
Yeah.
Yeah.
But Kelly, we have about a minute,
Yeah.
less than a minute left. What's something that you should um focus on with diabetes, pre-diabetes, type 1? Yeah.
How about this? I'm going to pull it back to the, you know, as you were talking about the major organs. Diabetes, as I shared, a lot of times you don't know if your blood pressure is too high, your cholesterol is too high, even when your A1C is high. Some patients are very in tune to it and they know that and they can feel it, especially with the high blood glucose. Some cannot. You want to make sure regular checkups, use the support of your providers, education. You know, you've got pharmacists to help you with medication, dietitians. We've got these classes that your nervous system, your heart, your diabetes accelerates atherosclerosis, raising the risk of heart attack, heart failure. You have to, you know, cardiovascular disease is the leading cause of death, but also in diabetes, your blood vessels, we call them large and small vessels. You know, it increases your risk of stroke and poor wound healing. You want to use the support around you. And if you don't have great support at home, you've got us healthcare professionals that are here to help you. Reach out because we want to make sure that you can manage your diabetes, you have the tools you need, and you can live a long and healthy life. We're here to support you.
And on that note, Dr. Kelly Cardamone, I want to thank you so much. And of course, you always bring out another point in diabetes we've never talked about, and that's been wounds. So, listeners, yes, you will hear another show on diabetes where we will specifically talk about wounds because we have never talked about wounds. And on that note, again, Kelly, I want to thank you, Dr. Cardamone, for being our guest this morning on the Great Lakes Health Radio program. And in 2 weeks, you will hear from my esteemed colleague, Cindy Bass from Erie County Medical Center. And on that note, I'm Francesca Messiah, your host from Kaleida Health. Be safe, stay healthy. Look forward to seeing you in the community. Bye-bye.